Well, I think that for a newly diagnosed patient with metastatic colorectal cancer, there are several options. Firstly, with regard to the chemotherapy backbone, one could either consider FOLFOX, namely an oxaliplatin-based regimen, or FOLFIRI, an irinotecan-based regimen. And what we know from the literature is those two chemotherapy combinations have equivalent efficacy. They have some differences in toxicities, but both relatively well tolerated and perfectly reasonable frontline regimens. My own preference has historically been to start with FOLFOX, but I think FOLFIRI is an excellent regimen. With regard to the biologics that should be added to these regimens, and I think there's compelling evidence to add a biologic, bevacizumab is a very appropriate addition. That is, the drugs that target the vascular endothelial growth factor pathway have considerable evidence of efficacy. There are several now approved, and the combination of FOLFOX or FOLFIRI and bevacizumab is reasonable. We also recognize that there is yet an alternative approach, namely using the epidermal growth factor receptor antibodies, cetuximab or panitumumab, and we know, for instance, from a recent CLGB study that 80405, that the comparison of either bevacizumab to cetuximab shows relative equivalence. So you could use an EGFR antibody or a VEGF antibody, bevacizumab, and get what likely would be comparable benefit. The caveat, of course, is that you need to assess these patients for KRAS mutational status because, as we know, patients who have a tumor that is RAS mutated, and not just KRAS, but NRAS as well, if there's a RAS mutation, those tumors do not respond to EGFR antibodies. So for a patient with a RAS wild type, and I mean all RAS, namely KRAS and NRAS, if it's wild type, then I think you can give either bevacizumab or an EGFR antibody. But if it's RAS mutated in either of the genes, KRAS or NRAS, then I would use bevacizumab.